Good afternoon and good evening, everyone around the globe. Welcome again to our MOH Connect from Dr. Erika Mendoza Clinic in Wolfsburg, Germany, where actually the magic is happening, where we have many activities done before with her, which was really much appreciated. And this is one of the kind of format that we do together when we bring live cases with patients to learn from her practice how things done. So thanks again, Dr. Erika, for being here. And of course, at Siglaris Group, we always strive to promote the exchange among different international global experts like Dr. Filippa and Dr. Muhammad Omar Farouk from Egypt and from Brazil. It's actually a pleasure also to be here with you and share your expertise, your knowledge, your comments with our audience. So having said that, it's actually a pleasure to introduce Dr. Muhammad Omar El Farouk. Dr. Muhammad is actually a consultant vascular and endovascular surgeon who is specialized in advanced endovascular and open surgery for critical limb ischemia and diabetic atherosclerosis disease. He also has extensive experience in complex endovascular surgery for aortic aneurysm and lower extremity occlusive diseases. Dr. Muhammad, he has a lot of interest and a lot of passion about education. So he has done a lot of other educational platform. He was graduated from Ain Shams University in Egypt, 1983, and he also did the training in England in Midland Vascular, West Midland Vascular Rotation in UK. Also, he is also a fellowship in the Royal College of Surgeons in England, and he's still also an examiner in the Royal College. Of course, he is also part of the organization teaching hospitals in Cairo, in Egypt. So I can continue saying a lot of things, what he created in terms of course designs, trainings, and other simulation tools. But I'm really happy that he's always eager to share his knowledge and experience with us. So with that, I give you the mic, Dr. Omar, to introduce our expert, Dr. Erika Mendoza and Dr. Farid. To you, Dr. Omar.
Okay, thank you very much, Dr. Mahmoud, for the great introduction. I'm privileged and honored to be one of the members of the MOH. I'm really excited today because there is something clinically new for every vascular surgeon to learn. This webinar is going to speak about how to preserve great saphenous vein, which is an important topic, but unfortunately it is not widely used all over the world. Let me introduce a great speaker and a great teacher and a great pioneer in the venous intervention, Professor Erika Mendoza. Professor Erika Mendoza have published a lot of books about her techniques. She do a lot of duplex courses. She run a clinic in Germany, and she is General Secretary of German Society of Phlebology since 2015. She is the current president of the AVF. She is also president of Phlebology and Lymphology Society since 2022 in Hanover. And she had a lot of meetings, a lot of interest. She's really keen about what she's doing, from the setup of her clinic to the way she managed her patient, to the way she really admired the great saphenous vein, and think anyone remove a normal great saphenous vein is a killer. She doesn't like that at all. And not only that, but I'm really privileged and honored by Professor Filippi Pacini, and I hope I'm pronouncing it right, which is a vascular surgeon with a special interest in phlebology. I have spent yesterday reading half of his publication. He published 38 peer review paper, fantastic paper, not just venous, but some of them on inflammatory aortic aneurysm as well. And he is author of many books, great books to add, and he has 38 publications from ultrasound-guided mini incision technique of Shiva to hemodynamic approach in Shiva, and really I can go on. So here we have 2 stars, 1 star from Europe, 1 star from South America, from Brazil, that will explain to us really in the Middle East technique that we need. which is great saphenous vein preserving procedure, Shiva, and the other technique. The mic is yours, Erica.
Thank you so much for your wonderful and very kind introduction. I will try to share my screen. We tested so many things, but
I can have a bit of discussion quickly with Filippo Vaccini. What do you think? I know that you are author of so many books. What is the main advantage of Shiva procedure compared to other procedures? Until when Erica, the PowerPoint gets in, she can just fire on straight away. Filippo.
Talk about a few advantages. The first advantage is that the cost is not a high cost compared to techniques that use modern technology. We have some clinical advantages. The thing is, I think it's the most important, is that most people think that nothing happens when you remove or destroy the saphenous vein out of a leg, but you leave a great portion of skin without a drainage. That skin has no drainage. So what's gonna happen? The body is gonna make new veins, and that veins will run a course really superficial until they find a perforator. That we avoid the recurrences that are created by saphenous destruction.
Yes.
One thing that I have actually a clinical case of that. A patient had a deep vein thrombosis after a plastic surgery operation. 2 years after, I have spared the saphenous vein of that patient in a Shiva procedure. The recovery after this was really easy, because I had previously patients with deep vein thrombosis after endolaser or after stripping, and the recovery was really bad. You have no way to the blood to return to the heart. And one thing obvious is that we have a bypass ready to be made if the person has like a coronary problem or arterial problem. So it's like a graft.
Excellent. I can see the great slides of Erica.
Yes.
You can carry on. Okay.
I'm back. I'm so sorry. We tried some things here, and I closed it and I didn't find it. I'm so sorry. Okay.
No problem at all.
We go just with the conflict of interest. Of course, MOH is Sigvaris, so I thank Sigvaris a lot. We have currently 3 ways to save the saphenous vein. No, we have 4. The first one is not treating every patient, only treating them if it's necessary, which in the industrial countries is not the most common thing. And if we treat a patient, we can do Shiva. We will go into that afterwards. We can do Aswal, which is like the Müller technique. You take away all the tributaries and preserve the saphenous veins. And we have the extraluminal stenting, where there is a put a cuff around the terminal valve. This is needing a lot of material, so this didn't really work so much. And when we come back to the Shiva, which we are presenting today, a special issue of Shiva is that in some cases, if there is no draining perforating vein or the saphenous vein in the reflux, we can eliminate the reflux, interrupting just the tributary and not touching the saphenous vein. And the result is that the great saphenous vein will work properly again, will recover the complete function. So we have 2 situations. I know everybody says, oh my God, shunt types and numbers and so on, but it is really very easy. We have a shunt type 3. This means we have a reflux from the deep vein into the great saphenous vein, into a tributary, and then draining to the deep vein. And we have no perforator vein on the great saphenous vein. And then you can do the following. If the diameter of the great saphenous vein is not too large, in real large refluxes, this will not work. But in small diameters, if you just interrupt the tributary, which was, of course, in the 80s only done surgically, you can have a permanent anterograde flow in the great saphenous vein in around 30 to 40%. But I mean, it is a third of the patients. You can completely preserve the saphenous vein, which is always an option. This is a clinical case. The lady had these tributaries, and we just did an interruption at this level, and this was 4 months later. No sclero, nothing, just a little interruption here, and the superficial vein disappeared completely as it was no longer fed by reflux, and the proximal saphenous vein was anterograde. The shunt type 5, which is 20% of the patients, is more interesting even. The important thing is that the terminal valve is competent. We had an MOH on this. Then you have a reflux from the tributaries of the groin down the great saphenous vein, down the tributary and draining. And in this case, if you interrupt the tributary with a flash ligation, you will have in 97% of cases a stable anterograde flow. So you have a complete competent saphenous vein just interrupting the tributary. And this is 20% of our treating population. So this is really an important thing. And the question if this will work depends on the perforating vein on the great saphenous vein. So I show you a little video on this from the German Society. This is the situation we have introduced now, no perforating vein. This is the other option, a perforating vein draining this flow. And to discriminate, this is just what we will do now with the patients, is we put the transducer here, we make a provocation maneuver like half compression or elevation of the toe. Here you see the tributary. And then if you close the tributary digitally and then make a provocation maneuver again, there is no reflux until you release the digital compression of the tributary. This is to show that there is no draining perforating vein. If there is a draining perforating vein, the reflux will just go on. This is a schematic representation of it. We have provocation maneuver, systole, anterograde flow, diastole, retrograde flow. We measure here, this is our finger. We close the tributary, of course not closing the saphenous vein. And we have the same curve as there is on the saphenous vein a draining tributary, perforant. So we don't need this tributary for the recirculation. If we close the tributary, the recirculation will still be flowing retrogradely through the perforating vein. If we have no perforator on the great saphenous vein and we make the digital compression of the tributary, you will have this lapsus without any reflux until you release the finger. And this is what we will do with 2 patients immediately. And I stop talking and I go on and pick the patient, and you can please discuss a little bit to allow me introducing the patient. Thank you.
Excellent. Thank you very much. That's a great start, a great introduction to what we're going to see in practice. And I will enjoy the experience of Professor Filippo Faccini, and also the opinion of Dr. Mahmoud Al-Ghadban with us. So a lot of surgeons are worried that of recurrence of varicose veins. So some of them remove everything, even if something is normal. How do you convince these surgeons to preserve a great saphenous vein?
Actually, I think who will convince them are our patients, because all I can see in those procedures that destroy all the veins is matting. And I do a lot of free operation from other clinics that in Brazil, it's like a trend to destroy all the veins. And I've done a lot of procedures and I've treated matting of several patients. I think the patients are gonna like filter this, but the problem is that they need a decade to filter this in the society. And sometimes it's hard to let this come. But I think this topic today of hemodynamic sclerotherapy is really important because I'm not here to discuss, for example, like a C6, an ulcer, like I'm operating one after this meeting, or a C5, a C4. The problem is that if you get the real life and even the clinical trials of most techniques now, the mainstay is C2. Sometimes they are the destruction of a saphenous vein in a C1 patient that comes to the clinic to complain about one little mark in the skin that that this telangiectasia is not beautiful, I'm not liking this. And into the C1 and C2 cases, I think it's like it's really bad what they are doing. So I think we need to move this conversation, and the patients will tell the surgeons
Yes.
what's the best time.
Yeah, that's a great
Yes.
approach. We're back to you, Erika, and
Yes,
we can
thank
see
you.
the patient. Yes.
We have a very kind patient, Herr Krumrath. He has data. He has a reflux from the groin to this tributary, and you can see until the lower leg there are varicose veins.
Yes, we can see
and
that.
I will explore the great saphenous vein at this level. We immediately will split screens and then digitally close the vein here, making sure that I'm not closing the saphenous vein. We will go through that now. Can we split screen?
Excellent. Yes, we
Perfect.
can see on the screen. We can see the duplex.
Yes.
We can see
Yes.
your
So,
probe in
this is the
the
classical
groin.
Mickey Mouse. We start here, but it is not the topic today, just to demonstrate that there is a reflux. And the reflux is emerging from this tributary and not from the deep vein. I will demonstrate it in just a second. You see there is a short, really short. There is no reflux from this at this place. We have one reflux from pudendal vein here. We have one reflux from epigastric vein here. And below the terminal valve, we have reflux in the great saphenous vein. And now we go to the place, we go down the saphenous vein. And here you see saphenous vein in the eye, saphenous vein going down healthy. And this is the tributary.
Yes,
So
that's true. Yes.
with bare eye, you see here the posterior accessory vein, which is
Yes.
putting also reflux into the great saphenous vein. And if I will position the probe here. But first, let me check one thing. I will go down. If I press we have here, if I press the vein here, the tributary at this place, yes, I make sure that I'm not closing the distal saphenous vein. This is important. The distal saphenous vein is in the middle here, and I'm compressing at this place, so I'm not closing the tributary.
Yes.
So now let's just make it with color. I will not close the foot of the patient. I would not. Can you show the foot? Geben Sie mal die Zehe bitte und runterlassen. When I get away the finger, when I press, nochmal heben und runterlassen, there is nearly no flow. When I release, there is more flow. But I will show this with PW. Einmal die Zehe heben und einmal locker lassen. There is not so much flow here. This one is better. The problem is that I don't have 2 hands, 3 hands. So, geben Sie nochmal die Zehe und runterlassen. There you see that there is no, if there is a question, if the notion is clear, there is no longer a reflux when I close this vein. The reflux is completely stopped. But I will try to make a better provocation maneuver that fits more to the patient. Gehen Sie mal auf die Zehenspitzen. Also einfach hochgehen mit beiden Beinen. Und runter. This one is good. Können Sie noch mal das Bein ein bisschen nach außen drehen? Ich weiß, das ist Sport. Okay, einmal auf die Zehenspitzen und runter. We have made tiptoeing, which moves more blood in the patients. Now I close the tributary. Nochmal auf die Zehenspitzen und runter. No reflux and reflux when I release.
Yes, that is very obvious. Yeah, very obvious.
Nochmal auf die Zehenspitzen und runtergehen. this is very obvious. This patient has no tributary draining on the brain saphenous vein. And you could say, okay, can have a look. Yes, here you see a tributary, a perforator, a little one. Nochmal auf die Zehenspitzen und runtergehen. No, it's like a shadow. It wasn't a tributary. Because we know that there are tributaries. Here it looks like that there is one. A very little tiny one at this place here. But if they are so tiny, they are not part of the recirculation. We've been talking about that in another MOH. And this is the reason why, obviously, it is not influencing the result. So if we close in this patient and the patient has a large great saphenous vein, if you see this is 9 millimeters at mid-thigh or proximal thigh, if we close just, this was the original Chiva approach was to say, we close between this tributary and here and leave the saphenous vein untouched.
Yeah.
Yes, we
Will
would.
this make the great saphenous vein to become small again?
Again, yes. I always say to the patients, it is like if you have a water in the garden to flower the flowers, to water the flowers, and you open at the wall and there is water coming out, and you close the tip. The water can't flow outside because there is no drainage way. If you close this tributary, the reflux can no longer be refluent because there is no place where the blood would drain to. So if you close this point, this one here at this level, then you would have a recovery of this vein in about 90% of cases. And this is why in the modern varicose vein surgery, they always say you don't need compression. You need compression in this case is up to the groin, because you have to help this vein to reduce the caliber. So this is a very important notion, that after this treatment we still claim for 6 weeks compression until here.
Until the groin.
Thigh long compression, because otherwise you risk superficial vein thrombosis, and this is the reason why we do always apply thigh long compression for 6 weeks. Yes,
that's a great point. Yes, that compression after this procedure will help the vein to regain its normal size.
Yes, because if you close the veins or you strip them, you have, of course, you may bandage the patients and use compression for 1 week, but there is everything what could be compressed is gone. But in this case, the things you are aiming to have these veins recovering, and this is why you need compression to support this.
Excellent.
Yes?
Excellent.
Okay.
Yes.
So if there are no further questions to this patient, I will come with the next patient, and you may just go on with your discussion, please.
Excellent. Yes? Excellent.
Thank
Very
you.
good. Yes.
Mouse.
Okay. So that's a very nice demo to the lecture.
Yeah, you also can get Dr. Philippa input on that, because I think we were discussing before investigating with the patient about the recurrent after the procedures. Also, I would like to highlight the compliance from the patient, because sometimes it's a big challenge, even when you advise with a compression class 1 or 2 for the patient to wear it for 6 weeks or 8 weeks. The compliance rate is not always high, and this is also something I would like to discuss with Dr. Philippa from his experience. So would you also recommend to the patient to put the compression for 6 weeks or more? What kind of precaution, also instruction related to the patient?
After therapy or after surgery?
After the intervention with the great saphenous vein, the same investigation for Erica did not.
I use compression for 3 to 4 days with a 35 stockings.
Yeah.
And additionally 10 to 11 days with 20-30.
Yeah.
I think it's class 2 and 3 in Europe.
Exactly.
35 and later 20 to 30, and only until we have 2 weeks. After 2 weeks, I don't use it anymore.
Yeah.
After sclerotherapy, I use for 1 week.
Good.
And depends on the size of the veins. I use those elastic stockings that I don't know the name there. It's Hobby. Do you have Hobby in
Yeah.
Europe?
Yeah.
It's 1520. 50 in the cases with small veins. And if I have those cases of sclerotherapy of really big veins, then I use a 2030.
Well, actually, Hobby, it's our brand name in Brazil, but we have something
So-
different in Europe and other markets. But it's really interesting to know because Hobby, we're focusing more on the prophylaxis and prevention of the recurrent more than both stage. But it's really good to know that you also apply gradually decrease the conversion from class 3 to class 2, so the patient get the benefits of using the different conversion classes. So Dr. Omar, for
Excellent.
your experience, what do you think as well?
Yeah.
Yes, I think it's a beautiful technique. And we need, as vascular surgeon, we need a great saphenous vein for operation like cabbage, like short bypass, like carotid using vein patch. So really to preserve a great saphenous vein is one of the definitely strong advantage. But I'm just surprised about the name of the stocking in Brazil is not Sigvaris. So
No,
Oh,
it's
it's
Sigvaris. It's one of Sigvaris brands.
one of the type of Sigvaris. Oh, okay.
Guys,
Good,
we
good.
have a 35.
Yeah.
And let me see the name of the 35 years.
Oh, brilliant. Oh, you got it in your clinic. Oh, fantastic.
35.
Yeah.
Most times I use Sigvaris here.
Excellent, excellent. That's very good because the quality of compression also really is very important, and this is what is in the European guidelines for both this procedure compression. Which way do you prefer, Professor Filippi, to treat these tributaries? You have multiple options. You have laser, you have foam, you have sclerotherapy, and you have mini phlebotomy. What is your experience? Which way do you do it?
I use always hemodynamics. For example, that case that Erica was showing, I think I would recheck the later portion, but it was only to demonstrate. So I think that collateral gets back to the saphenous vein in the leg, as because of what I've seen in the leg. But for example, in that case, if there was only that vein coming out of the saphenous vein in the tire, I would take that vein, do a ligation at the place where it goes out of the great saphenous vein, and I would take like 3 to 5 centimeters of the upper portion because it's too big to make it easier for this vein to wilt. Because most of the times, if you do the ligation of the vein, the rest of the vein wilts. Have you seen the PERTS test? I don't know if
Yes.
you do that in Europe. Actually, PERTS was from Germany, I think, and
Oh, yes.
it's really interesting because you put elastic bandage in the thigh of the patient and send the patient to walk. You see that most veins disappear. So the veins that the people are treating are veins that can disappear with a rubber band. And I
Yes.
don't see point in destroying all that vein. So I do the ligation. And sometimes we have high static expectations from a patient. In these cases, we sometimes later finish with sclerotherapy if some vein is still appearing.
Excellent. Do you like to comment about Dr. Mahmoud?
Yes, I'm ready. I'm all.
Oh, excellent. And we are ready to.
Okay, so we have don't want to tell the name. I did a mistake earlier. So a wonderful lady here, and we start. I first Felipe. He was doing a great point with the distal great saphenous vein. I can tell you the last patient had it didn't go inside the great saphenous vein back. So now we will do a toe elevation maneuver. Einmal Zehe heben und runter. Und immer nur einmal, wenn ich sage. And we see again, I've selected 2 patients with competent terminal valve, that the reflux is not coming from the deep vein. Einmal die Zehe heben und runterlassen. The terminal valve is competent, yes. And we
Yes.
have a reflux below the terminal valve. Einmal Zehe heben, runterlassen. Or not. Einmal auf Zehenspitzen gehen. Und runter. Möchten Sie sich ein bisschen weiter hier herstellen, dann können Sie besser. Nochmal einmal auf die Zehenspitzen und runter. I don't know what's happening today, why the toe elevation maneuver isn't so effective. Okay.
Maybe the bending can help.
Einmal die Zehen nochmal heben, nur, genau. We go back to color to make an image of the reflux. You see that below the terminal valve here, you have an inflow from the epigastric vein on the other side of the valve leaflet. And we go down the vein. And again, the vein is not too small here. In the groin, we have 7.8 millimeters. And at proximal thigh, we find 6.5 millimeters. I will recheck here. Einmal die Zehe heben. Runterlassen. There is a reflux.
Oh, yes, that's a reflux, yes.
Yes? So
yes,
I've brought
that's around 1.5 seconds. Yeah.
Second, yes, yes, large after. I have brought a patient with a problem because normally I said I close the vein with the finger, but you see here, this is the saphenous vein, this is the tributary, and it is almost always running over the great saphenous vein.
Yes.
And we have a connection here. Yes. And we had a perforating vein here. So we could expect the reflux elimination maneuver not to work. To say, okay, there will be a perforating vein. Yes. Here is the connection. Einmal Zehe heben und runterlassen. But it doesn't look like there is a big exchange between both.
Yes.
In systole, when I press, it is always blue in both, and in diastole, it is only red in the superficial vein. Yes, this is the saphenous, this is the tributary. So you will see that in these cases, it is difficult to find the point to press properly.
Yes.
Yes, but I will try. Here it moves a bit away, a bit here. Entschuldigung. Okay. Einmal die Zehe heben und runterlassen. This is the emerging point of the saphenous of the tributary. And I release the finger. Einmal auf die Zehenspitzen gehen und runter. I release the finger and the reflux comes. So again, in this case, we can demonstrate that all these little connections we have seen, all the perforating veins, this very little one here, this connection here is hemodynamically not relevant because the reflux stops when I close at this point, the tributary, even though the tributary starts already here.
Yes.
Coming back to Felipe's question, I will go down the vein because in this case, really, there is a connection at the ankle. So we have this accessory superficial vein running down, parallel to the great saphenous vein, down. Here is a connection between both.
Yes.
Einmal auf die Zehenspitze gehen, bitte. Und runter. But it is not active. There is no flow here inside, if you see that.
Yes.
And we go further down. Further down. Here is another tributary leaving behind to the back of the leg. And this is the superficial accessory vein that was filled with reflux all the time. Einmal die Zehe heben und runterlassen. And we have no longer a reflux here, but at this very, very low point, einmal die Zehe heben oder runterlassen, there is a little reflux. at the anchor region einmal zerheben und runterlassen. But it is, this complete segment is without reflux, and it leaves to the tributary, it leaves into another tributary, and then comes back here. So for me,
Yes.
I would consider this vein as a healthy vein in the rest. If the reflux would go back to the saphenous vein at this level, we would have this segment refluxive and this segment refluxive. I would reconsider my strategy, because if the vein has only a short segment without valvus, the possibility to recover completely is less. But we have 2 points.
Yes.
We have a competent terminal valve, and we have a very short segment of reflux. So the interruption at this point, at this where the tributary emerges the first time, an interruption at this point would be the option to have a competent saphenous vein afterwards.
Excellent. That's a great demo.
Yes? Okay,
Yes.
so we can say thank you to the patient. Alles klar, dann können Sie einmal gehen.
Yes.
Danke. And just if you allow me to say something more.
Yes, please.
This was what I learned from Claude Franceschi, and when I met Felipe in October in France, he told me that he was doing these cases without surgery. I mean, I do sometimes do foam sclerotherapy like we do in Europe when the tributary is far thinner. You know, everybody knows these cases where there is just a little reflux and everything goes in the tributaries, like this case, but much thinner everything.
Yes.
I already did sclerotherapy, but I was impressed with his presentation that he does this with sclerotherapy, and I would think we should run the movie from Felipe and afterwards discuss everything if that is okay for you, Omar.
Excellent.
Yes?
Excellent. Excellent.
Thank
That's
you.
a great idea.